Rodrigues, Magalhaes. I'm from Brazil. It's a great pleasure to be here today. I'm going to talk about peripheral artery disease, a comparison of virgin open and endovascular revascularizations on the public health system in Brazil from 2010 to 2020. This article we published last year in the journal Vascular Brasileiro. So, peripheral artery disease is caused by atherosclerosis that provoke arterial obstructions and is associated with high rates of cardiovascular morbidity and mortality. From 2000 and 2010, the prevalence of this disease increased by 13.1% in high-income countries and by 28.7% in medium and low-income countries. Critical limb ischemia is the most severe form of peripheral arterial disease and is defined by ischemic foot pain and rest, ischemic ulcerations or gangrene, and requires surgical treatment. Surgical bypass and endovascular therapy are the principal revascularization strategies used to treat critical limb ischemia. Historically, open surgeries were considered the gold standard for these patients. However, over the last 2 decades, the endovascular revolution has significantly increased the use of these percutaneous techniques for treatment of ischemic limbs, with countless reports of excellent limb salvage rates. This was the descriptive cross-sectional observational epidemiological study with the aim of carrying out a comparative analysis of the surgical and endovascular revascularizations performed on the public health system in each region of Brazil. Data were extracted from DataSUS, which is the Ministry of Health database in Brazil, from January 2010 to December 2020, to analyze procedures performed on patients with critical limb ischemia. The Praise-Witten method was used to conduct a temporal analysis of the results. So, in Brazil, in this analyzed period, we had a total of 83,218 urgent admissions for both procedures, surgical and endovascular, with a total cost of about 333 million of reais on hospital stays and procedures, as shown in the table 1. This figure 1 illustrates the relative frequency of these procedures conducted in each region of Brazil. Like we see, there is a difference between the regions. Regarding the surgical procedures, this table shows that a total of 27,086 admissions were approved for open revascularizations, with a total cost of about 94 million of reais. For Brazil as a whole, the mean hospital stay for open surgery was 10.2 days, and the overall in-hospital mortality rate was 5.24%. Finally, calculating the rate of admissions for open procedures, as illustrated in this figure, a non-static and falling trend was observed over the period analyzed in Brazil. And now, regarding endovascular procedures, the table 3 shows that there were 56,132 admissions and a total cost of about 239 million of reais. The mean length of hospital stay for angioplasties was 5.3 days, and the in-hospital mortality rates was 1.56%. Contrasting with the trends for open surgery, we observed a non-static and rising trend for the endovascular procedures in the period of 2010 to 2020. The figure 6 shows a comparison between the in-hospital mortality rate for the open and the endovascular surgeries. Like we see, the mortality rate for open procedures was higher than the rate for angioplasties. And additionally, the figure 7 illustrates the relationship between the number of open and endovascular procedures in this study period. So this study showed that in Brazil, from 2010 to 2020, there was a greater number of percutaneous techniques with around twice as many endovascular than open surgeries. And we saw that the temporal analysis of rates of open procedures revealed a falling trend, whereas the trend of endovascular procedures was rising for all regions in Brazil. Similarly, several studies have also talked about the endovascular treatment increase. Data showed that the percentage of angioplasties increased from 13.4% to 27.4% from 2001 to 2011. A study evaluating patients admitted for critical ischemia from 2003 to 2011 showed a significant reduction in the proportion of patients who underwent surgical revascularization, 13.9% to 8.8%, and a corresponding increase in endovascular procedure over the same period, 5.1% to 11%. Another study, also conducted here in Brazil, showed a significant change in the proportions of treatment strategies used for peripheral arterial disease over the years 2008, 2010, and 2012, with a 57% increase in endovascular procedures and a 9.8% reduction in the clinical treatment, whereas the conventional surgical treatment remained stable. Beyond that, the management of peripheral arterial disease is costly for the healthcare system, like we showed in this study. The economic effect of this disease is substantial, with an estimated annual cost of about $12 billion in the United States alone. Comparing the two procedures, the total cost of endovascular admissions was around 2.5 times greater than the cost of open revascularization in the present study. This is primarily because of the increase of the number of endovascular procedures over the analyzed period, about double of the number of admissions for open surgeries. However, it is also important to us consider the higher cost of the materials employed for percutaneous techniques, in addition to the fact that the database used for this study does not enable analysis of reinterventions, because some studies have shown lower patency rates and greater probability of reintervention in patients treated with endovascular procedures, which could indirectly counterbalance the proportional costs of endovascular and open procedures over time. Modern tools for endovascular treatment are more sophisticated than in the past, and there is no doubt that the costs have increased with the new generation of guide wires, balloons, drug-eluting stents, and other modern materials. While the new technology has the potential to improve technical success and durability, there is a financial cost that must be taken into consideration. But it is important to point out that the mean length of hospital stay was 10.2 days for admissions for open revascularization, whereas the mean stay for endovascular procedures was 5.3 days in this present study. A multi-center study was conducted for 2013 to 2016 and showed that the total length of hospital stay was also significantly shorter for endovascular procedures when compared with open surgery, 3.4 versus 10 days. And it found that the adjusted cost of an endovascular procedure plus hospital stay was 42.3% less than the cost of open revascularization, probably because of the shorter length of hospital stay and reduced use of intensive care service related to angioplasties. Moreover, analyzing hospital mortality related to these procedures, this present study observed a rate of 5.24% for admissions for open surgeries, and in-hospital mortality rate for endovascular procedures in Brazil was only 1.56%. This author, Tang, conducted a meta-analysis comparing the two types of procedures in patients with peripheral artery disease and demonstrated a significantly higher overall mortality rate for open procedures when compared to endovascular treatment, 10.86% versus 7.54%. In addition to a shorter length of hospital stay, lower rate of complications, and lower amputation rate among the patients treated with endovascular surgery when compared to those who underwent conventional surgery. However, there is no statistically significant difference in survival rates or limb salvage at 30-day, 1 year, and 3-year follow-up. Furthermore, the BASE trial was a completed prospective, randomized, and controlled study that has compared endovascular techniques with surgical revascularization in patients with critical ischemia. This trial assesses 452 patients with a 3-year follow-up and did not find a difference between the two groups in the primary outcome of amputation-free survival, 57% for open surgery versus 52% for endovascular treatment. There was also no significant difference in relation to cost or long-term quality of life. However, the study has several limitations, since it only analyzed intraluminal angioplasty, excluding other technologies like stenting, and did not describe the influence of the pattern of arterial obstructions. But very recently, the best endovascular versus best surgical therapy trial was published in the New England Journal of Medicine. There was an international prospective randomized open-label multi-center superiority trial with the objective to determine whether endovascular revascularization was superior to surgical bypass in patients with critical limb-threatening ischemia caused by infrainguinal peripheral artery disease. They divide the patients with a segment of a great saphenous vein in cohort 1 and the patients without a single segment of great saphenous vein in cohort 2. In the results, they showed that the median length of hospital stay was longer in the surgical group than in the endovascular group, 6 days versus 3 days, as well as we saw in other studies. But in patients with a good quality great saphenous vein for conduit, a surgery-first strategy was associated with 32% lower risk of major adverse limb events or death than was the endovascular strategy, 57.5% versus 42.6%. A result that appeared to be driven by fewer major reinterventions and fewer above ankle amputations in the surgical group, not in the endovascular group. However, in patients without a great saphenous vein for conduit, overall efficacy and safety outcomes appear to be similar in the two treatment groups. These findings suggest that among the patients with an indicated saphenous vein who were suitable candidates for both surgical and endovascular revascularization, surgical bypass with a vein was a superior initial strategy. To finish, as we saw, in recent years, the frequency of endovascular therapy as the initial revascularization strategy has increased. Excellent limb salvage rates and low perioperative morbidity and mortality have been reported as use of endovascular treatment has become widespread. However, questions have been raised about its durability, costs, and applications. We need to evaluate factors such as conduit availability for bypass, advanced age, and renal failure in the planning revascularization procedures. It is also very important the team approach that leverages experience with both strategies to treat patients with critical limb ischemia most effectively. So thank you very much.